There has been an explosion of menin inhibitors in the last few years with a dedicated session at ASH this year just focusing on menin inhibitors. As you know, there are 5 different menin inhibitors on the market right now really competing in this very exciting space. I think it's a fantastic emergence of a drug class targeting patients with NPM1 mutation, KMT2A rearranged AML, and NUP98 rearranged AML, and potentially more other subgroups like UBTF10 duplication. In the relapsed refractory setting, I must say that the single agent data is very promising. You know, they have response rates, overall response rate up to 50% or more with CRs, combined composite CR rates of 30 to 40%. And I know a lot of these companies are now bringing the menin inhibitors up front to combine with either intensive chemotherapy in the younger fit patients or with venetoclax azacitidine-based triplet therapy for the older patients. And some data have shown that recently seems really promising. So it will be interesting to see what the randomized phase 3 studies show, because ultimately, we have to show superiority of adding in a menin inhibitor on top of standard of care to be able to bring it forward to standard clinical practice. But I think that's an extremely exciting space from an efficacy standpoint. From a toxicity standpoint, menin inhibitors are oral medication, so that the ease of administration is a big benefit, but they do have issues like QTc prolongation, though more in some drugs, less in others. They have issues with thrombocytopenia, and I'm actually quite interested to know with the triplet therapies, especially with azacitidine and venetoclax, which already causes thrombocytopenia, how the addition of menin inhibitor will change that tolerability, especially in a older patient population. So that's something that I will be looking out for very closely for the studies that are upcoming. It can also cause interactions with other drugs like azole medications like posaconazole. So I think it will be interesting to see how each of the trials handle that in the future. But I think overall it is a very promising class of drugs, and I'm really excited to see where the field will lead us and who truly benefits from this class of therapy. Another aspect that I would be really interested to look at is in the post-transplant setting, especially for patients with positive measurable residual disease, whether menin inhibitors could play a role there. I think that's something that is up and coming as well, and we'll be very interested to see what data will come from that aspect.